This is Tom Lee, editor-in-chief of NEJM Catalyst, and we're talking today with June Lee, the CEO of Emory Healthcare and the EVP for Health Affairs at Emory University. The topic is, what will it mean to be a great AMC in the era before us? That very much is the goal that Emory and June discussed when I joined them recently at a day-long retreat. There's a subtopic, which is, how do you turn around a dire situation of financial deficits and serious morale issues, which is what the last several years have been about at many academic medical centers. I know both of these issues will have wide interest, and June has some interesting things to say. So June, I know you have a fascinating personal story, but we don't really have time to talk about it today. I will just note that you trained in cardiology at Massachusetts General Hospital and went to UPMC for more than 25 years, where you moved into steadily expanding leadership roles. And then you joined Emory Healthcare as a CEO in 2023 and became the EVP of Health Affairs a couple of years later. Can you describe the situation at Emory when you arrived in 2023? Financially and otherwise?
Thank you so much, Tom, for certainly the opportunity, and it was great to have you visit during our retreat. It was really impactful and meaningful in terms of the dialogue there. Really excited to continue the conversation now. As you noted, I started at Emory as CEO in July of 23, and for many of us, last 5 years is such a blur. But that was a little over 2 years into the pandemic, and certainly Emory Healthcare as an entity, which was at that time a 11 hospital academic integrated health system in greater metro Atlanta area, was facing many of the problems I think that a lot of academic health systems around the country was facing. It was still what I would call the peri-pandemic era, the effects of the pandemic, less medically, but much more in terms of socially and financially, were still rampant in terms of how health systems were operating. So Emory Healthcare is really the only comprehensive academic health system in Metro Atlanta area, which is kind of a unique type of a situation. But we, on the negative side, as a health system, when I came, were facing still the tremendous repercussions of what many have termed the Great Resignation, including an employee turnover of 40% first-year turnover, 30% overall turnover, and total reliance on contract nursing to get day-to-day work done. I think that for many of us, that'll be kind of a familiar scene if we turn the clock back to 2.5 years. And it wasn't totally unique for Emory, but certainly Emory was really facing this crisis and as a healthcare organization. So along with that, the morale was low and financially quite a bit of struggle given the high cost of the contract labor, had not gained the efficiencies, and I would say the organization was a little bit lost in terms of where it was going. And to make matters worse, the management leadership had lost some credibility with the board of directors, so there was some tension there. But more importantly, I think the management had lost some credibility with the workers, frankly, in terms of its ability to lead through the turbulent storms that were really the aftermath of the pandemic. But I would argue were really a culmination of many pressures that have been building in American healthcare systems for a long time. The pandemic just exposed in all its glory, unfortunately.
Well, that's a tough situation. People think of Emory as one of the pillars of American medicine, but you're describing a range of challenges, certainly not unique, that were coming together during the pandemic. Now, you and I, when we were training in cardiology, we learned how to address cardiogenic shock in a patient with myocardial infarction, but leading a turnaround for an academic medical center and the system around it, that isn't really something we learned about in medical school. So how did you go about it?
Yeah, and certainly my experience, as you noted, I'd spent a long time with increasing responsibility and at UPMC, it really helped a lot. It was not the same. The markets were different. Some of the situations were different. Some of the thematic components were different, but many were the same, and certainly had some very strong beliefs about what was foundational in terms of creating a high functioning health system. And I came in, and my leaders all aligned around the fact that we knew for the health systems to build for the long term and to rebuild for the long term, if you want, becoming a highly reliable, high performing organization, that it ultimately meant that we had to get our workforce who were very invested and believed in what we were doing. And that was missing. It was actually kind of paradoxical because when I first came in, of course, like many new leaders, I went around trying to meet as many people as possible. And oftentimes when I would ask about what was best about Emory Healthcare, people would say, it was the people. And I think that was very much true. Met people who are still here, who've given 20, 30, 40 years. We're celebrating tonight service awards, and we have many people who've been here with us for 45 years. So that is part of the strength. And then when I ask people, what's our biggest threat? They would say people, partly because we didn't have enough. And people were losing faith in what Emory itself had. So we knew that the central focus we needed to have was to both rebuild the workforce, but also regain the trust and align ourselves in terms of that. In addition, I have a very strong belief that with the continued change in the American healthcare system, that in order to thrive, the winners versus the losers, the winners are going to be the health system that ultimately can function as a system, not as individual hospitals. And what we found were that the hospitals in Emory were functioning much as really well-meaning and trying to do their best, but the leaders were functioning within their silos. And so we made aggressive structural changes to change that so that we function much more as a singular system. And that's not, as you know, that doesn't happen through just saying, hey, we're going to function as a system. We made changes in terms of job descriptions, in terms of leadership personnel. Instead of having CEOs for individual hospital, we created COO positions with system-oriented president positions who had responsibility over multiple campuses, made it clear that the hospitals were working with each other, emphasized service line type of a structure that forces much more of a coordinated care between different campuses. So all of these together created really a different operating model. And we also set very high aspirations. We were very clear as leaders in saying what we want to do is to become the premier academic healthcare system in the US. Not just the regional health system, but premier at setting a paradigm for what academic health systems could do. And it's really important to have a goal that we can align around, have a workforce that's invested, and get that expectation, if you will, that only the highest quality and the highest performance is going to be what's acceptable for all of us. So, it's not any one thing, but all of those things together. And you mentioned, those aren't things that are taught in medical school, and for maybe a later time. I think that's one of the big challenges of being physician leaders. We're not taught so much, and as becoming leaders, and if we're taught to be leaders, it's really kind of a clinical leader in terms of leading clinical teams. But fortunately or unfortunately, the modern healthcare, complex healthcare, really melds the need to lead interdisciplinary teams, understand the economics, and how do you create organizational strength. Those are all critically important for us to be effective from a clinical standpoint at this time.
Some of the things you mentioned are so important, like the appointment of COOs rather than the CEOs at the specific hospitals. And I hope that in some other format, we can come back to those someday. But for the time we have, I want to concentrate on those morale issues that you alluded to. And I hate to tie morale so much to money, but compensation is important. And around the country, I know that physicians at AMCs are struggling with workforces that feel underpaid and they don't trust their leadership. And we're seeing unionization at the places that you and I trained at, as well as other reflections of lack of trust. If you're open to it, can you talk about how you thought about compensation and how you dealt with that?
Yeah, it was a critical area. Now, I would say the difference is we were aggressive, but also honest with ourselves in terms of what the situation was. What I mean by that, when I first came, once again, and talking to the leaders, I would sit down with, the OR units and kind of variety of people who are working together, really dedicated a workforce that we had. And I would ask them about compensation, how we're doing, and then look at the analysis. All our analysis said that kind of we're at the median or a little bit above that, at least the analysis I was getting at that time. But when I asked the teams, the struggles were the same. We were losing people. We're losing people locally. I mean, not just the national question of not having enough nurses, surgical techs, and whatnot. We're losing people locally, and that it's like having clinical data that does not compute, right? Having a normal creatinine, yet someone producing no urine or something like that, a low cardiac output state. It just didn't make sense. And I was really fortunate to have a wonderful HR or people team with Rock Anderson and Sarah Schockler, two of the figures who really helped to transform. And we took an honest look and it said, okay, we're in the local market. We weren't so good. And we were honest in admitting that mistake. We also made a huge bet that in order for us to get to where we need to get to, we need to invest in our workforce. Retrospect, it seems like a no-brainer, but I do have to say that it caused some consternation because at that time, we still did not have a positive margin, but we decided to aggressively invest in the workforce. In essence, we can't expect 75th percentile type of performance, which was what we were preaching, if you're paying people below the 50th percentile. That was never going to work. And we so aggressively invested in terms of pay for throughout the workforce. At that time, we had about 25,000 people. We did it in phases, and overall, about 21,000 people were affected. And we're not talking about 1 or 2%. We're talking more in the range of 10%. And for many of the nurses, about $10,000 or more in terms of what their yearly paycheck would be. So, but we put it in the context of our goal that for us to succeed, that we aspire to be the best place to work. And we termed this effort in terms of becoming a market leader. And that was done during the winter of 23, when we hadn't quite made the financial recovery. And we knew we were taking a risk, but we were aggressive about it. And we were also very public about it, meaning that we wanted people to know that we're making an investment. We wanted our team members to know we're making an investment in them and we're betting on ourselves, was what we said. And we wanted other people to come and work for us, so we wanted them to know. So initially, we even went in front of the Atlanta Journal-Constitution, which is a local newspaper, and said we're making a $100 million investment in the pay raise. And that really raised a lot of eyebrows. Well, it turns out that we did it in phases, aiming at kind of 6th to 75th percentile in terms of the pay in the local market. And it ended up being about a $270 million investment on a yearly basis. But it really paid off in terms of we were able to reverse the tide. So, the 1,500 or so contract nurses came down to less than 100. We were able to really establish a core workforce, which everyone knows. is a better workforce to establish a coordinated care, the efforts to become more of the system, other things that we talked about needing to benefit our performance. But I think an important thing is that we didn't view this just as a pay exercise, but once again, our chief people officer and his team, I know you're going to probably interview him later or have a discussion with him, but they looked at it as an overall package. So looked at the benefits. We invested to make sure that the medical insurance costs did not increase. We didn't want it to be kind of giving a raise on one hand and then increasing the cost, out-of-pocket costs for medical care for our own employees. We made sure that we created training programs. So it was really a comprehensive effort to make ourselves a better place to work where people can develop their careers. And I think that that made the difference. A large part of our story, the finances are the easy part to kind of quantitate, but a large part of our story is switching how our own team members thought about us, where we were going. We definitely took some chances in the early days, but then having a comprehensive view and perhaps having a chief people officer who was outside of healthcare may have helped in that regard because Rock had worked for-profit industries and for different type of companies and brought some different perspectives, which we found very helpful in some of the efforts that we undertook. And like I said, that was a large part of it. And I'd be remiss if I didn't mentioned the soft components. That is, during this time, we made sure our leaders were out there and made sure that it was a dialogue, that we were listening to what the needs were and trying to deliver in that regard. And there's no doubt that that really helped us to rebuild the trust and to establish that. So right now, in 3 years, we've expanded quite a bit. We've gone from 25,000 to 30,000 team members in terms of the whole organization. Fortunately, the unacceptable numbers of the 40% turnover, we're down to about 22%, which is still too high for first year turnover. And then our overall turnover went from about 30% to about 13%. So we still have work to do, but we're at a point where certainly our ability to build is much better than it had been before.
Well, that's an amazing big bet story. And I'm delighted to hear the turnover statistics, but how are things going big picture beyond that? And what are your hopes for what comes next?
Yeah, I mean, we've been very fortunate. And obviously, as we said before, the hypothesis was, yes, we're going to bet on the people. We have to have a core workforce, along with the other changes that we've made, working much more as a system, functioning much more efficiently. It's really a broad scope effort, and we've had a great, really 2.5, 3 years in terms of the finances. So really proud of the fact that we've gone from really a $5.8 billion organization with functionally a negative margin. We had a less than 1% EBITDA of around $50 million. This was our fiscal year 23. We've increased that revenue from 5.8 to 6.9 to 8.1, and we're about a third way through the current fiscal year, and we're projecting a $9 billion. And that's done with minimal amount of merger and acquisition. That's really growth in terms of volume on the same campus. So we've gone from, in 3 year period, about 5.8 to 9 billion, and we've increased the EBITDA from about 50 million to we're projecting around $1 billion. So over 10% in terms of EBITDA. Obviously, we're incredibly proud of that, but that's only really a small part of the story. I think the more important part is we feel like that we have the trust and faith of our team members. One of the things that this has done is they've seen that EBITDA and margin is not some type of a fictitious number, that generates our ability to continue to bet on ourselves. And we make sure we visibly show that we're pumping that back in terms of continued competitive pay and continued benefits. We've worked really hard despite our own healthcare costs increasing, we're self-insured like most organizations our size, we've really pushed the out-of-pocket expense for our employees. And in contrast to most of the industry, actually kept it the same or actually decreased that for those that are making less than $100,000. And they've seen the investment that we're making in the system to pump that back in, that's allowing us to grow. My example is right now, like most health systems, with the flu season and starting with a kind of a maxed out capacity is really busy, and we don't have quite the capacity, and yet the attitude and what we're able to do now is markedly different. And that's really due to, I believe, the culture that we've been able to create through really this kind of a dialogue and investment in the workforce and what we've been able to do and what the team's been able to do for the last 2.5 years.
Well, wrapping up, I have to bring up one of the grim jokes I hear from some of our colleagues at academic medical centers, where they say they're just trying to be the last iceberg to melt. That clearly is not your goal, and not what you're hoping for Emory. So, what are the key themes and strategies you see for the years ahead? I mean,
Yeah.
I know you want Emory to define greatness for AMCs for the decades ahead. So, your thoughts on what that will look like?
Yeah, absolutely. Obviously, our aspirations are high. And the last iceberg comment, I often comment, look, strategically, where do we want to go? I can't tell you what the world will look like in 2030. I have some ideas in terms of healthcare, but what I can tell you is that hold your breath strategy is not going to work. That's what I mean by that is, a lot of people during the peri-pandemic period kind of took the approach. I'm just going to hold my breath and try to survive through this. And then the good old days of 2018, I don't know if they were really the good old days, but certainly through, the color glasses, the good old days will return. Obviously, that is absolutely the wrong attitude. And I believe that we're facing a period of existential crisis for academic health systems. I believe academic health systems are critically important for the future of the American healthcare system. It is a center of innovation. It is where so many good things have come. But we have to change in order to thrive and to continue to have that impact. And that's what our journey is really about. We believe that we can create the paradigm for how academic health system can thrive in the future. And what's happened over the last 2.5 years, which we've been talking about, you know, I I I I try not to use the word turnaround because it sounds like we're done with the project and we can go back to our old ways, because that's exactly opposite of what we're trying to do. We view the momentum that we have built as really the building blocks. That combined with the tradition of excellence, the tradition of innovation that has always existed at Emory and many other academic health systems. How do we combine that? You know, we can't use being an academic health system as an excuse to be inefficient. That's not the hallmark of academic health system. If it is, we're not going to survive. It's really innovation. It's really excellent care. And we have to infuse that with a certain amount of efficiency so that we can actually compete in the real world and thrive, yet keep what's at the core. There's no single answer to what that paradigm is, but we have some ideas about where we're trying to go. I'll tell you an anecdote. When I initially came, about 3 months into my journey here, one of Sarah Shockley, who's the chief of staff for HR, sat me down and says, "Well, tell me what success looks like for you." And I told her, I want us to look totally different and feel different, yet people understand and feel that we are Emory. That is, how do we make sure that we preserve what's really at the core of academic health systems? Why do we need academic health systems? Yet, how do we change the business practices? How do we change some of the expectations? Separate the inefficiencies, the kind of some of the old habits that we need to shed to modernize, yet preserve what is really contributory to society about our academic health system. That's really the goal. Obviously, a lofty goal, but unless we strive for it, unless other academic health systems strive for it, we're not going to create that new future.
Well, June, I want to thank you so much for your comments. I think that the work you've done is very, very impressive. And I think your vision and your optimism are, are brilliant. And I think that I think betting on Emory is a very good bet in terms of showing what it will mean to be a great AMC in our era. I know that we are going to be talking often, and I hope you'll continue sharing your insights and lessons learned, and encouraging the rest of medicine that we can make progress the way you are at Emory. So thank you once again.
Well, thank you so much for the opportunity, and thank you for the opportunity to tell our story. I think that, I believe academic health systems and academic medicine has a bright future, but it's not preordained. It has to be earned. And that's all of our jobs as leaders in academic healthcare.